Good afternoon. Welcome to the weekly press briefing. Could I ask the speakers to introduce themselves to the left?
Damien McCallion, HSE National Lead for the Vaccination Programme.
Anne O'Connor, Chief Operations Officer.
Paul Reid, CEO.
And Mark Brennock, National Director of Communications, and Mike and Lisa are our Irish Sign Language interpreters. And could I ask Paul to give us a weekly update?
Thanks, Mark, and good afternoon again, everybody. There's no doubt over the past 16 months, everybody's been living with a lot of unpredictability related to COVID, and we all want to get closer to a space where we have some predictability back in our lives. And I guess now, more than any time, people would like to see that emerge and like to see the finishing line so that we can get back to that space we all want. But it's equally true and fair to say that there's one big hurdle in our way for the moment that we have to cross, and that's related to the Delta variant and its potential impacts between now, August and September. I guess like trying to cross any hurdle, we should go into it with a level of confidence. Firstly, confidence that the vaccination programme is giving more protection every day to more and more people. Secondly, confidence that the testing programme is continuing to scale up and identify sources of the transmission levels and virus and contacts. And thirdly, confidence that the vast majority of the Irish public will once again do the right thing, support the public health measures as society is continuing to open up at the same time. But it's equally important that we do take the Delta and the threat of Delta very serious in the next few weeks in particular. None of us want to lose the very strong position that we've got ourselves into through the vaccination programme. We can see it in terms of all the indications of the virus, that where it's growing and the level it's growing at. We can see its very strong impacts overall. Compared to last week, the 5-day average is up 95%, and the 7-day average is up 93%. But compared to 2 weeks ago, the 5-day average is up 160%. And 7-day average is up 150%. And compared to last week, the overall 14-day incidence rate is up over 66%. But on vaccinations, equally, we should take good confidence in what's happening there. The programme, there's no doubt, it's really flying overall. It doesn't seem long ago, since early January, when we were doing between 20 and 30,000 per week, trying to get to the older, vulnerable people in nursing homes and healthcare workers. And now in July, over 1 million vaccines alone administered in July. So it's really exciting now also that we have the vaccination programme open as we speak to those over the ages of 18 and regularly having done 300,000 per week over the past few weeks. Just in terms of the further opening of the economy and reduced restrictions in the next short while, from a HSE perspective, we welcome the engagement that has happened with key stakeholders involved in this process, open up the hospitality sector. And we're glad in the HSE that we have played our part in supporting those discussions. Throughout the pandemic in the HSE, we have always said long-term lockdowns, long-term restrictions is not good for society. It's certainly not good for the economy. And we know in the long term, it's not good for the health service either. And we know that because we treat some of the long-term implications, whether that's through issues of physical health or issues of mental health. But the challenge for us all, the public, ourselves, proprietors of business, is to now embrace the planned opening up in a very safe way and don't put ourselves at further risk for the next few weeks in particular. So in this regard, I would make a special call to the public, continue to support the public guidance, and particularly if you are symptomatic, to please isolate, arrange through your consultation with your GP or test one way or the other. On hospitalizations, as you'll have seen from today's reports, we're at 95 people in hospital and 23 now in ICU. But we do know we haven't seen the worst impacts of what we see models coming out in the next few weeks. So in those days in January that everybody remembers, we were watching hospitalizations rising at alarming levels. Hasn't happened as yet, but again, we do know we're in the early stages of potential impacts of Delta. But thankfully, we are coming off a lower base. with the numbers that we currently have. But I do just want to make a few general points just in terms of hospitalizations. First of all, the trajectory of the disease we do know is having higher transmission levels and higher positive cases in younger people, and that's specifically due to the vaccination programme. Secondly, though, it is far too early to draw any conclusions or indeed any comfort about what this may mean for hospitalizations in the coming weeks. We do make the case again that every COVID patient in our hospitals has a disproportionate effect, not the patients themselves, but the fact that they're a COVID patient has a disproportionate effect in our hospitals in terms of putting in place the infection prevention and control measures, isolation processes that have to go on, etc. That has a very significant impact for every one case of COVID. And indeed, regardless of the illness that any person may have been hospitalised for, once they've been identified with COVID or having COVID, they'll be continued to be treated for COVID because COVID makes people very sick. So our concerns remain high about the potential impact of hospitalizations through August. If we are treating higher numbers of COVID patients throughout August and September, it poses a real threat to us through the progress we've been aiming to make in the last few weeks, to getting back to non-COVID care, to getting back to elective care. And none of us want to turn the dial back down on that one again. So there is a time that we want to ensure that in the coming weeks our exhausted healthcare workers do get a chance and get a break during the coming weeks. We know the impact it's had on them for the last 16 months, and layer on top of that, for the past few weeks have impacted them in terms of the cyber attack. So again, call to public, please treat the Delta variant with the seriousness that it merits in the coming weeks. Please continue to support our public health advice, particularly as sectors open up and supporting compliance with those measures. Please do continue to mind your families, friends, and any interactions that you will have in the coming weeks, whether that's indoors or outdoors, or at home or socially mixing. Just a particular mention also to younger people who have been vaccinated, and just to really watch closely the protection period. You know, it's not from the day you're vaccinated, but there's a time period after that before you're fully protected. And I say that because we have seen incidents of people being vaccinated very quickly or immediately travelling away and contracting COVID, coming back in positive. So I do make that special plea to younger people also. On the vaccination programme, just to summarise, overall now over 1 million doses administered since the beginning of July, 5.34 million vaccines administered up to yesterday. Over 3 million people now have received their first dose or single dose of vaccine, 80% partially protected. Almost 2.5 million have received their second dose or single dose, 66%. 2 in every 3 adults now fully protected. Uptake remains strong across the vaccination programme for the age groups, and very briefly again, 99% over for the 80s plus, 98% for the 70s plus, 70s, 79s, 95% for the 60s, 69s, which you'll have seen has come up dramatically in the past week or so, 93% in those aged 50 to 59, and 87% for those aged 40 to 49. Approximately about 73% at the moment for those aged 30 plus, but they're not fully completed there yet. Last week, the week commencing July the 12th, the plan was to deliver over 300,000 vaccines, administered them, and we administered over 358,000. This week, again, our plan to administer 300,000, and we're well on track with over 150,000 done up to yesterday. And next week, again, we will be targeting towards 300,000. On the vaccination ages, again, good to see the portal continued on for starting with the 20s as it now opens to the 18s to 24s as of Wednesday, 21st of July. The rollout of the shorter interval period of 4 weeks for the AstraZeneca dose 2 has commenced, and we're practically completed all of that. Just on testing and tracing, to give you a few final numbers, a few updates and figures on it. It's the dashboard that you'll see displayed there. Demand continues to rise and rising quickly and sharply, but we are meeting all of the demand that's coming at us, and we are meeting it in the timeframes, the turnaround timeframes that we have been meeting, still maintaining those. Testing volumes are up 15% on last week. The positivity rate in community testing and for walk-ins and self-referrals is over 10.5%. Overall testing positivity in the last 7 days was 8.8%. And some sites, as we mentioned previously, seeing positivity of 25%. Testing sites in Dublin, Donegal, Louth, Galway, Meath are particularly busy. Additional capacity is being put in place in some of those places, particularly in Louth. In the past 14 days, 75% of the cases have been in those under the ages of 34 and 32% under the ages of 13. Close contact workload, obviously based on more close contacts, is up 88% on last week. Close contacts are at 3.7 per person. And again, I do make that call to everybody. If you are contacted by our contact tracing team, please do reflect and feedback all of your close contacts. We're conscious some people may be reluctant to give all the close contacts. It's really important that we do. 10% of the cases last week came from those with a travel history or in the prior 14 days. And we are continuing on to build up capacity, as we've mentioned previously. We are looking at community testing. We have capacity for swabbing in the community of between 20 and 22,000 per day. Overall, we've built up our lab capacity to over 30,000 per day at the moment. We have reached days of 16,000 per day in the community. We do envisage when we get to 20,000 per day in the community, we will utilise antigen testing for close contacts, and details of that are on our site and will be communicated with people should we be deploying antigen testing. Looking at the numbers, the trajectory of that, likely at some stage towards the end of next week, if they continue at the rise levels we've seen. We are putting in extra capacity, as I just mentioned, for lab tests of now 30,000 per day. We're also putting in extra hours, extended hours into our centre, more swabbing pop-up centres as required around the country. And we have secured resources for those swabbing centres if we need to scale up further again to those levels. And as I mentioned, antigen testing we will deploy as appropriate. I'll leave it at for now and I'll pass you across to my colleague, Anne O'Connor.
Hi everyone. We'll just talk through where the services are at. And we'll just start with a very quick summary on the ICT situation. So day 67 now since the cyber attack. But you can see there a lot of progress has been made. So we now have 94% of our servers decrypted and 85% of our end user devices. Patient management systems all available now. There's only one site that has limited function in the diagnostic imaging. Labs, 37 sites now functioning. Radiotherapy, 3 sites. Endoscopy has 26 sites and 11 sites still having a limited level of function. And that relates to one system in particular. And colposcopy, we have 13 sites functioning and 1 site having a limited level of function. So really significant progress across the board in terms of IT, and any of the issues that we have now are really quite site-specific or related to integration. So actually systems and the whole service, I suppose, working as it was before, we're not fully there yet, but a vast improvement in the recent weeks. So in terms of where we're at across the system, we haven't had data available, as you know, for the last 8 weeks or more, but we've now got to a point where we are able to look at some of the data that's very important for us in terms of managing the system. And in terms of our waiting list, this is something that we had presented a few times before in where we're at. And you can see here in relation to our outpatient waiting list, that has grown considerably. So you'll see we had the date up to the 13th of May. That was still very high. We had started to make some inroads in our outpatient list late last year, but the surge from January to March really affected that. So our ability to do outpatient work was severely compromised and impacted even further. So as we started to get back into that activity, the cyber attack had a very significant attack. So you can see there that our waiting lists have grown really very significantly now, up to over 647,000. And that's a huge number, obviously, and something that we have to really focus on. In terms of outpatients in general, it has not been, I suppose, as critical in terms of being able to work during the COVID period as a lot of our inpatient case. So inpatient and day case work was prioritised. In terms of our position compared to last year, and we have compared it to last year, you may recall this time last year, we were in a bad enough space in terms of just getting activity back, starting to reopen last summer, really, May, June last year, getting activity back in, and that's the green line. So the red line is where we're at this year. So a considerable difference, 9% more than where we were this week last year. There are, there's some caveats in this in terms of we haven't got all of the data. We're going to be populating those gaps, but we feel we have a good enough view now to be able to I suppose, demonstrate where we're at. In terms of our inpatient day case, that hasn't been as impacted. The number is we still have 77,000 on our inpatient day case list, but we have improved from January. So that, has gone up a bit since pre the cyber attack, but a lot of work going on, making sure that we are bringing people in. And we can see that in our activity in terms of the amount of scheduled care that is being booked in. And our inpatients, so when you look at this year compared to last year, you can see that it's 5.7% of a difference there compared to last year. So that is, still an improved position on 2020. We are continuing to prioritise now procedures that have been cancelled either because of the earlier surge of COVID or as a result of the cyber attack, and a very significant amount of activity going on around that across the country. Interestingly, when we look at scopes, we can see that actually that activity is down compared to this week last year. That's actually a surprise for us. We thought that our scope activity would be a lot worse than this, given, and even as I said in the earlier piece, we still have some of our endoscopy systems still impacted. Now, this may be a data issue, but we think that it is actually fairly close to where we might be. So scopes hasn't, so that would be colonoscopy, etc., gastroscopy, that hasn't deteriorated as much, and that may be related to the fact that a lot of our big hospitals in the east were continuing activity, so we're looking in behind that. But you can see that it is an improvement on last year, notwithstanding the fact that we still have a lot of people, so still 34,000 or in excess of 34,000 waiting there. When we look at what we're doing around waiting lists, there's a lot of interventions underway to reduce waiting lists across acute and community services. Important to note that, traditionally, when we talk about waiting lists, we talk about hospitals all the time, so it's people waiting to get into hospital or outpatients. But critically, there are very significant waiting lists in the community, and we're now starting to look at these in a more standardised way across all of our services. In relation to acute services, we've had the NTPF working very closely with us for many years, but in recent times particularly, they've identified extra capacity within the public system, so for an additional 1,000 cases per week, and they are working with us very closely on that. And the NTPF look at high volume activity, so hips, knees, cataracts, that kind of thing. And they're going to focus in these extra 1,000 procedures per week on gynecology, ENT, ophthalmology and orthopaedic procedures, as well as a few others. We've also, in parallel to that, completed a tender process for surgical procedures for patients that wouldn't normally be covered under the NTPF. So these aren't the big high volume ones, they're the other types of procedures. And that now is going to, so there's about 600 procedures on that list, and we will be drawing down from that tender, working with the private system on that. And again, we hope that that will have a considerable impact. So they still account, those 600 procedures would still account for about 50% of our waiting list. So it's a very important initiative. We have released through our scheduled care transformation team about 15 million into the public system to increase activity. And that is really through additional hours within our own system. So a number of initiatives there across our acute services to really, and as you can see from the figures, a really urgent need to have an impact on some of those lists. In terms of our community services, they have been doing a lot of work. Their system, I suppose, is different to the acute system. They're not involved with the NTPF, so we don't have the same level of visibility. Generally speaking, in community services, those lists are held at a local level, and we are now looking at how we can kind of capture that in a more standardised way. But we are now looking at community lists, and again, they are forming part of the scheduled care transformation. So for the first time, we are bringing the community lists into that space to look at how we can really run initiatives in the short, medium and longer term to have an impact. So a huge amount of work going on, and this work is core business in terms of just really trying to have an in on those waiting lists for people who've been waiting for appointments now for a very long time in some cases, in other cases not so long, but just to assure people we have a number of different things underway on that. When we look at the activity across our emergency departments, we can see that we've had quite a high number, still running higher than 2019 or 2020 across our emergency departments, and our admissions similar to last year. So the admissions, when we look at them there, we can see that we have really a 1.7% reduction on last week in terms of our attendances, but still up 18.7% on the same period last year. So still running higher. Admissions only 5.1% on the same period last year. So really what I'm saying is the system, when you look at that and the activity around addressing our waiting lists, our services are extremely busy across the board. When we look at our over 75s, we can see that that is running significantly higher than last year or the year before. and admissions similar-ish. So we can see that we're 15.2% higher than the same period last year for attendances of people aged over 75, and we're 6% higher in terms of admissions. And we know that when we have older people in our system, it is a different experience. We have people who are admitted and generally stay longer in our system and often have more complex care needs. Our patient experience time, we can see that it's 1.3% down on the same period last year. So notwithstanding the fact that we are busier, we're managing to maintain that at a good level. We're 14% down, however, on our over 75s. Now, again, that is related somewhat to the data challenges we've had and how we're entering that data. But clearly, we'd like that to be higher than it is. In terms of our trolleys, very busy across our system this morning, 200 people on trolleys across the country, and that's 77 higher than last year and 108 higher in 2018, or sorry, down 108 in 2019. In the past 7 days, the average number is 164. And we can see that when we look at where that is, we have high levels of presentations at a number of sites, so particularly down in the west and the south. So if you look at Galway yesterday, 229 presentations in the emergency department yesterday, 23 patients on trolleys this morning at 8 o'clock. Limerick, phenomenally busy, 274 presentations yesterday and 35 people on trolleys this morning. Kerry had 121 with 19 on trolleys. Sligo, 137 with 19. Again, when we look at Cork, though, 220, so significantly more than the same day in 2019 or last year, and 32 on trolleys. And the Mercy, interestingly, down in presentations, but up in terms of people on trolleys. So we're seeing that, you know, the system overall is extremely busy. Again, just to remind people that our emergency services are there for people who need to be seen. You will be seen if you attend. But just to link that, I suppose, in terms of the COVID numbers, the reality is the system is incredibly busy across the board. I think I've said that often enough now. But in terms of actually bringing people into our hospitals who are also sick from COVID, the pathways and the whole, I suppose, working of the service is hugely impacted. It is impacted in terms of the COVID and non-COVID pathways, the demands on the system, the different ways of working, etc. And with this level of activity going on, it's quite a challenge. Today, we had 95 people hospitalised with COVID, which is up 19% on the same day last week, and up 150% compared to the lowest day on the 25th of June. So you can just see that graph going up in the last number of weeks. Our ambulance activity is still running very high. So again, we're up against that red line there in terms of the overall activity. And critically, the graph on the right-hand side, where we've gone way over and above the projected trend, is the emergency transfers to hospitals. So this is where people are being brought into hospital by ambulance. And that number is still running much higher than what our projections would have told us. Generally speaking, our NAS projections are very accurate. So this indicates how busy the ambulance service is as well. And again, we have a lot of people out and about enjoying the fine weather, but that brings with it a higher level of trauma, accidents, etc. Again, just to emphasise the other pathways for people. So in terms of people who have injuries, and particularly this sporting weather, sporting injuries, sprains, strains, we have minor injury units around the country. Information is available on our HSE website for all of that. And again, our emergency departments are open for business. But if you think you are very sick, please contact your GP in the first instance. Thank you.
Good afternoon. I just want to bring you through some of the disease indicators where we stand in relation to the vaccine programme. So looking at the 14-day instance first, we're now back up at 256 per 100,000, far below the peak of January, but nevertheless on the rise. The 5-day moving average similarly peaked much higher, almost 7,000 in January, now just over 1,000. Hospital admissions, you've heard, 86. Rising slowly. ITU admissions, 22. What we tend to follow is the average number of new admissions, looking at tracking the new admissions per day, and that's averaged out over the past 5 days at 15, 16 new admissions per day, which is up from when it dipped there several weeks ago to well into signal figures. So we're seeing a rise in a new hospital admissions with COVID over the past week or two. So cases are rising. We reported yesterday 1,378 confirmed cases for the first time since the end of January. This, again, caused a concern, showing the disease is now prevalent in our communities. Hospitalization is rising, not so high as it was. It's gone down a little. This is 96 yesterday, but nevertheless, as I said, not just 5 or 10 per day, now up to 15 per day. And ITU admissions rising 22, an increase from last week's 20. Looking across the EU, we see that volatility that's been a hallmark of COVID from the very beginning, where countries that are highly performing or poorly performing can change in a matter of weeks. Now we see Cyprus, a case increased dramatically in the past few weeks, also on the rise in Spain and Portugal. And within any country, of course, there's remarkable volatility too. And here we see the dramatically high 14-day instance in Donegal, not representing, of course, the whole county, but particularly in Nishowen, Buncrana, Letterkenny areas, Louth to Dublin, all quite high, and at the other end of the scale, Kilkenny maintaining a very low level. So there's been much remarkable the age group here, and the majority of cases, 75%, are in the under 35 category, and it remains the case a very small proportion, 2.9%, are in the over 65 age group. The real concern, of course, that 19 to 24, 25% of cases in that age group, 19 to 24, and that's where the disease is thriving and where it's transmitting at the moment. Is that the same elsewhere? Of course it is. This is Israel's data, with the majority of adults in Israel now vaccinated. Just over half of the country's new cases in the month up to the 5th of July were in people aged 19 and under. And this trend, that this wave has been driven by younger age groups in the presence of more transmissible variants, is being noticed not just in Ireland, Britain, Scotland, but Israel and elsewhere. So what are the outbreaks? We've looked and we've referred to this, the vaccine program, as a flood wall that holds tight but isn't absolutely impermeable if the water level runs high enough. That flood wall is holding tight where it matters. We're still seeing very small numbers of outbreaks in nursing homes, community hospitals. That's one in the past week. 3 outbreaks in acute hospitals, one particularly large one. Otherwise, the outbreaks in other settings where you have more unvaccinated individuals. So this is an experience, again, there's been much commentary on the vaccination status of people who have suffered seriously, whether it's deaths or admission to ITU. So this is a slide shows the deaths in between May the 14th and July the 13th in Ireland. There's 70 altogether. Now, during this period of time, the Delta began as a low instance variant, and eventually became the case where it's by far the dominant variant, well over 90% of cases. So it wasn't steady state Delta throughout this time. Of those 70 deaths, 41 were unvaccinated individuals. It's 59%. A smaller proportion, just about a quarter, were partly vaccinated. And the smallest proportion occurred in those who were fully vaccinated, of which 100% were over 65 years of age. Additionally, of the 12 fully vaccinated deaths, only 2 people died 14 days after being fully vaccinated. So what about ITU? Again, looking at the experience of ITU admissions, again on the severe end of manifestation of COVID illness. And this is between March the 25th and July the 11th. And the majority of ITU admissions in this time period, and let's just remind you again that during this time period, Delta went from being absent to present to growing quickly and now becoming the dominant variant. So of the 131 ITU admissions in this time period, March the 25th to July the 11th, 80%, 105, occurred in the unvaccinated population. A smaller proportion, 15%, in the partly vaccinated, and the smallest proportion, 5%, in the fully vaccinated. Of the 26 patients who were admitted to ITU and were at least partially vaccinated, almost 90% had an underlying condition. So harm is still, the most severe harm as a consequence of COVID, still occurring largely, more often than not, in older age groups and those with vulnerable conditions, something we've known from the very start. This analysis, I just want to acknowledge the work of NOCA and our ITU community in putting this together. These are the 4 waves, if you like, of COVID. The first wave is way back in February, March, April 2020. The second is in autumn 2020. Wave 3 was the wave we saw really at the beginning of this year, and then there's a current snapshot. This, and the orange bar shows the total number of cases in ITU in each wave, and the grey bar shows the average age. In the first wave, the average age was 60 years of age. In the second wave, which was less severe, smaller number of cases, it was 67. In the third wave, when our ITU system was running well into excess beds, with over 400 patients being provided with enhanced care outside even ITU, the average age was 62. In this current wave, the average age is 52. So what this shows is, it implies at least, that the unprotected younger age groups are still at risk of serious illness and hospitalization. Breakthrough infections, there's been some misunderstanding, understandably, of vaccinated versus unvaccinated. And you've heard the figure throughout the week that about 20% of people hospitalized with COVID are vaccinated. This can mislead us about vaccine effectiveness if we don't consider the underlying vaccination risk rate. So if you look at the right-hand side, what really matters is what proportion of the vaccinated population can catch COVID. And the truth is, we know that the vaccines that we use are at least 90% effective against the most serious aspects of COVID, namely hospitalization, ITU, and deaths. So a much smaller proportion of vaccinated individuals are going to be admitted, and a much smaller proportion to ITU. And we'll see even a much smaller number of cases, whether they're admitted or not, in vaccinated individuals. Impact. So what happens when there's a rise in cases? If we use a flood wall analogy again, an increase in number of cases or a rising tide increases the chance of everybody testing positive for COVID-19. Obviously, particularly in unvaccinated, who are also at risk of more severe disease, hospitalization, death, but not exclusively so. It's also possible that if the flood level rises high enough, that vaccinated individuals will be affected and the flood wall is breached. So the left-hand number of cases, left-hand side, where we have low numbers of cases, we see predominantly cases in unvaccinated individuals, much less so in vaccinated. With high number of cases, it will impact ultimately also in vaccinated individuals, because even the vaccine, as good as it is, isn't 100% effective. First dose vaccinations, the EUA, we're still performing very well in relation to other European countries. You've heard about the percentage of age groups that have been vaccinated, which remain really, really high. I'll touch on the younger age group just at the end. But we see levels far beyond what we would have hoped for. And even with the projections of herd immunity that we need to reach rising, we're well on target for reaching hopefully over 90% if those younger age groups keep up with the same level of enthusiasm and engagement the older age groups have in terms of registering and receiving the vaccine. The variant update in Ireland, the latest S gene analysis, which is a marker for the Delta variant, shows that well over 90% of cases are now Delta. So it has easily displaced the B117. It is now the dominant variant in our country. Analysis from Public Health England of 123,000 cases. Of the total cases detected, 8.8% were fully vaccinated. Of those, that proportion that went to ED presentations, 15% fully vaccinated. And of those who died, 257, almost half were fully vaccinated. And an older age group. So the harm pushing towards older, more vulnerable people all the time, even those who are fully vaccinated. And this is a study, the Siren study I referred to before, NHS healthcare workers, 45,000 participants, 95% vaccinated. They're tracking them all the time, looking for evidence of reinfection, and they're finding a slight upstroke in the past few weeks. So that breakthrough, that wall, that flood wall being breached a little, given the astonishingly high number of cases in the UK of 50,000 plus per day. So the risk there in Public Health England remains transmissibility high, infection severity, probably increased hospitalization, but hard to say it's more increased than alpha. Impact on immunity after natural infection low. Reduced vaccine effectiveness, certainly after the first dose, but less so after the second. Finally, just coming to England, we're seeing a rise in cases in all age groups, particularly 16 to 24, I referenced this already. And deaths in all age groups have significantly increased in the past 2 weeks, particularly in the over 75 cohort at a faster rate. That's the red line. Hospitalizations per 100,000 have risen in England, as have patients in ITU have increased from 116 at the end of May to 567 the 26th of July. And we're seeing that replicated in the US. Hospitalizations, deaths rising, deaths not so much, and cases rising. And this is Israel, again, rising cases, rising hospitalization, albeit from a lower base. Briefly, herd immunity. There's been much discussion. You'll remember last year, people asked about herd immunity and what proportion of the population needed to be covered in order to make sure we could stop the spread of COVID-19 and reach a critical threshold or inflection point beyond which we could say that we could stop the virus effectively replicating and transmitting throughout society and reduce the chance of further mutations. This is a function of two things. One is the transmissibility of the virus and the effectiveness of the vaccine itself. And because we're dealing with a much higher transmissible variant, that threshold has now probably gone up to as high as 85, 90% in terms of the population we need to cover to achieve what is called herd immunity. So, summary, Delta variant is spreading worldwide, much more transmissible. The EU prediction of a month ago that 90% of cases will be Delta by the end of August has probably been achieved already. Higher rates of hospitalizations and deaths, particularly in unvaccinated and partly vaccinated, and some countries reintroducing some public health measures. Finally, I'd just like to say yesterday was an important landmark in our vaccination programme. That online registration was open for those aged 18 to 24. Vaccination against COVID-19 now available to all adults living in Ireland. We've seen very high levels of uptake so far in our programme, and this was evident yet again yesterday as we saw nearly 40,000 people register. We know from other jurisdictions that uptake tends to dip as you move down through age groups. We've consistently outperformed other countries in the older age ranges, and we must do all we can as we face this new Delta wave to similarly ensure high levels of uptake among our younger population, notwithstanding the challenges that may entail. The signs in this regard are hopeful, as over 64% of those aged 20 to 29 are now registered for a COVID-19 vaccination, which has already almost matched the uptake rate of 65% among the same cohort in the UK. I would appeal to younger people to register and receive a vaccine as soon as possible to protect themselves and their family and their friends. Thank you.
Okay, thank you, Colin. And now take some questions. Richard.
Hey, Richard Chambers from Virgin Media News. I just want to ask first about hospital admissions. Tony Canavan from Sales Group said that the majority of the patients with COVID-19 that he's seen in his hospitals in Sálta were admitted for other reasons. What proportion of COVID cases in hospital at this point are admitted for other reasons? At this point, do we have any specific numbers on that? Will we be able to see more data published on that as well?
There are three ways people acquire. First of all, they have symptoms of COVID and are detected by clinical suspicion and present that way. The second way is through surveillance, which is where they're deemed to be a close contact, or there's an outbreak, and they're tested as part of the public health response within a hospital or elsewhere, and they're picked up that way. And we've seen that happen in nursing homes, in hospitals, right from the start, where a number of people are picked up because, not because they're symptomatic, but because it's part of a sweep or screen following an outbreak. And the third is hospital-acquired COVID, which is where somebody comes into hospital with something else and acquires COVID. And we saw that rage through our hospitals, particularly in January, when the levels of hospital-acquired COVID reached as high as 1,000 per week. So what we see, thankfully, we have a relatively small number of patients with COVID in hospital at the moment. The great majority of these are there because they're sick with COVID. In some cases, there are outbreaks, and in those outbreaks, people have been picked up who either didn't have symptoms or had very mild symptoms because of the outbreak, whether it's a screening process, as Tony very well described, where in one outbreak, one of his hospitals, in the Sálta Hospital Group, they screen patients and staff and discover, in his case, in one of those cases, I think 16, 17 patients and staff have it. And there's nothing unusual in that. We found that in nursing homes and otherwise. It doesn't diminish the threat, because we know, as we've heard 100 times, Richard, how transmissible this virus is. So whether you're symptomatic or asymptomatic, if you have COVID and you're a patient or a staff member in a hospital, be it Mayo or otherwise, you're going to run the risk of passing on to somebody who may ultimately become very ill with it. At this point in time, what I can say is the patients in ITU, the 22 we described, they're there because they're sick with COVID. The average age has dropped. but the same proportion of those are ventilated as were ventilated in previous surges in terms of patients in ITU, albeit at a smaller number, 22. And of the absolute number of, I think it's 90 today, the great majority of those patients are unwell with COVID. There are some who are detected through outbreak.
General message that we want to relate to the public: if you're hospitalised with COVID, you're quite sick. Nobody gets hospitalised if they're not in need of hospitalisation, or indeed in many cases very sick. And even if you contrast back to January, when we had 2,000 people in hospital, and listen to the stories and the recollections of Bernie Waterhouse, clinical nurse manager from St James's Hospital, talking about how sick people were. So we would be concerned that the public may get an impression that people aren't as sick or not in hospital because they're sick with COVID. There may be a small, tiny proportion of those total numbers were admitted through a different channel for a different illness, but they are being treated for COVID now as well. And talk to any of our nurses or frontline staff, they'll tell you the people they're treating for COVID are very sick.
I ask as well, just in terms of capacity that's there, how much extra capacity is there with regards or in comparison to last year? And as well as that, what would be an unmanageable level of hospital admissions? We've sort of seen, as sort of Colin was going through, about 5 to 10 or however many a day. At what point do you start to get very worried about that?
I think that so capacity, it's important when we talk about capacity that we don't only talk about hospitals. So our health system capacity starts with community services. And in reality, we did this in the previous surges, so as COVID was going up, we were doing more in the community. We had our community assessment hubs, we had different ways of working with GPs, et cetera, et cetera. So we have grown capacity, not just in terms of beds. So if you look at the fact that we have the GP access to diagnostics, we have a range of integrated care initiatives, we have a range of initiatives with our National Ambulance Service, and beds are just a part of what we do. And then we have beds in the community, we have subacute beds, and we have acute beds and additional ICU capacity. So I think when you look at, the winter plan for last year, the national service plan for this year, we have been bringing in capacity. Our ICU capacity has increased, our general acute beds have increased, and we've got subacute beds, as I said. But really, one of the biggest impacts for us has also been the investment in things like home support. Very significant investment in additional capacity there. So I think our health system capacity, as opposed to just hospitals, is the important point to reference. In terms of at what point do we become worried? Really, the first step for us is to try and keep as many people out. The second step is then to look at how much scheduled care we're doing. Now, when you look at the unscheduled care activity that I referenced there, we have sites that are incredibly busy by virtue of unscheduled care attendances, and that drives activity in most of our Model 4 hospitals. So it's the unscheduled attendances that drive a lot of the activity. And then you have to look at what capacity we protect for scheduled care. So the next step is you scale back on scheduled care. So you have a way of managing the capacity all the time and bringing it back more and more just to emergency work. So really, we're not there yet. And I think, we just have to look at the rate of increase. So yes, the numbers have grown. They're not massive. It's still a relatively small number. It's still manageable. And we are continuing, when you see the waiting list that we have, it's an absolute priority for us to continue doing as much scheduled care as we can. But even that's tricky in some sites by virtue of the other activity, the unscheduled work that's going on. So a very long-winded answer, but it's we're not there yet, but it's, we are watching it very, very closely.
In terms of, Colin, your figures there, you were going through fully vaccinated people or partially vaccinated people admitted to ICU or who had died. Is there any estimate in terms of the impact on immunity or efficacy from vaccines for people who have an underlying condition? Like if you were saying for Pfizer, you have 90%, efficacy in preventing severe illness or hospitalization. To what extent does that drop down if you had a serious underlying condition?
Thank you. It's a good question. We know from previous vaccination programs, including ones we've a lot of experience in the flu vaccine program, that there are subgroups who don't respond as well in terms of immunological response. Older people, immunosuppressed, certain conditions don't generate an immune response and won't get the same degree of immunity. However, what I would say is the real-world evidence of the vaccines we're using is very robust in terms of demonstrating clearly the extremely strong effect these vaccines have in reducing serious illness, as represented by hospitalizations and death. And those figures are very robust for all the vaccines we're using. So the breakthrough infections we're seeing are not absolutely a surprise. If we see enough If we see enough infection, enough community transmission, there are people out there who've been fully vaccinated who won't have generated a complete response. And the more chance they have of meeting somebody else who's carrying the virus, then it obviously poses a threat to them. But every vaccine program has these loops or loopholes in them, in the sense that they're not completely effective. We know that. But it just reinforces the message that we need to reduce community transmission, not just for the unvaccinated, but for the vaccinated too.
Yes, yeah.
Shauna Bowers with the Irish Examiner. Kind of touching on what you said earlier, Paul, you said the next 3 weeks are quite important in terms of delaying increased cases and hospitalizations. Is that in line with the vaccination program? Is that why you're saying 3 weeks?
Yeah, not specifically 3 weeks, but I think throughout August we will get a much better understanding of pattern and trends. We always know there's a lag effect on cases and hospitalizations and ICU, generally at least about 2 weeks. So we're starting to see increased cases. We would expect to see in the coming weeks increased hospitalizations. So it's not just for the 3 weeks, but I think the next 3 weeks will give us a much better understanding of what's going to happen over the next 3 to 6 weeks. So I don't see the threat stopping after 3 weeks. I think we'll get a better understanding of the patterns and trends.
And you mentioned last week that we are near the point of having to defer care, and I know you kind of touched on it at Richard's question as well, but are there any sites which have already begun to defer scheduled care?
Because of COVID. So there are sites that are closely watching because of the unscheduled care. So the sites that have very, very high unscheduled care presentations are watching it. We haven't, there's no national view, but that's normal business for us. So a site may have to just cancel some people for the next day if they have particular bed capacity challenges, but it's not to do with the COVID situation.
I had another question. Oh, yes, sorry. I write it down in different places. I can never follow my notes. You mentioned earlier that long lockdowns and restrictions have negative impacts even for the health service. Are you beginning to see those impacts now, perhaps like mental health presentations and things like that?
A few aspects that we are seeing and have seen, and we've been reporting on here. We know the impacts if you take on young children being out of school for longer periods of time. There's been reports published by our own paediatrics and the RCSI demonstrating the long-term impacts on children for that, so we know that. We know from what we're seeing from emergency department presentations, people have not presented during a period of restrictions and frailty and other issues becoming worse and more intense and needing more care. We know the impacts it's having on mental health in some of our mental health clinics all across the country and what they're seeing based on delayed presentations coming forward. So yes, and we also know in terms of the impacts of long COVID itself as a medical issue, but in terms of lockdowns, restrictions, yes, we know they hurt everybody and they hurt the health service over time. Needed and required at points in time, but do have impacts.
One clarification point, do you have numbers to quantify the mental health presentations that the clinics are seeing?
No, so I think that we know that certainly our CAM services are busy. In terms, I don't have data on me, so in terms of the actual referrals, but I think it's important to note that the mental health services are one part. There are many other places where people attend that we wouldn't capture. So 80% of mental health presentations are to GPs in the first place. So I don't have a full rounded view of that, and I don't have the performance data on me at the minute. But we know, and we also know that we have seen a significant increase in attendance at our eating disorder services, both in terms of children and adults in particular. And that has, well, children in particular, but eating disorders overall in particular has been a very significant increase. So we are looking at that as well.
Paul?
Excuse me. Paul O'Donoghue from Newstalk. I suppose actually just to start off on your last point, Anne, when you're talking about that increase in eating disorders, could you give a bit more detail around the number of presentations, how it compares to, say, last year, for example, and what's being done to address it?
I don't have that data on me, sorry. In terms of eating disorders specifically, we can get it. I think we've given it before.
I personally have visited some of our CAM services, and they specifically will talk to you about eating disorders becoming more prominent over the last few, particularly over the last few months in particular. So we don't have the data, but certainly it's a strong team coming through.
just the Taoiseach said yesterday that there's kind of an expectation now that there might be 3,000 to 4,000 cases per day at the peak of this wave of COVID. Does the HSE have similar expectations for that?
Well, we've been working off the NEFA data, so the 4 models that were from the optimistic to central 1, 2 and pessimistic. You know that the indications are from NEFA that it's trending on certainly at the start, it's trending on the central 2 to pessimistic. We would have modelled that throughout now in terms of impacts on hospitalizations and ICU in the coming weeks. It really depends what happens in the next few weeks, because we have seen the cases surge, go from 600 very quickly to 11 or 1,200, but kind of hold between 11, 12, 1,300 for the last few days. So it's hard to determine fully the impact on hospitalizations and ICU at this stage. And that's why, Sean, I made a point. I think we'll have a better indications over the next 2 to 3 weeks.
Then just on herd immunity, I think, Colin, you were discussing it earlier. You mentioned a figure of about 85 to 90% because of how transmissible the Delta variant is. So presumably that means that we'll need to vaccinate children to reach that threshold. Would that be right?
Well, this is a challenge across the world in that what we thought initially, based on much cruder estimates a year ago, based on the wild type we were the wild type of COVID we were dealing with last year, the estimate was 60 to 70% of the population. But because we're dealing with a much more transmissible variant, to reach that concept of herd immunity, which we're quite away from, every country's far away from yet, the estimate has gone up to certainly 85, 90%. So yes, it by extension would include populations extending into children too.
I suppose on that then, presumably you're going to be expecting NIAC to approve vaccines for children then, because if it's needed for to reach that herd immunity threshold.
Herd immunity is one. I brought it up not because it's an absolute goal. Obviously, it's a preferred goal we have, but in advising vaccination for children, NIAC, like other agencies right across Europe and the world, have to consider the relative risks and benefits for children, for whom COVID-19 presents a very low risk in terms of serious illness, hospitalization, ITU and death. And that to balance what is a very low risk against the risks that any vaccine may have in younger age groups. So you can see that between the joint committee in the UK, who I don't think have recommended so far for children, while they have in the US, there's disagreement internationally in this as to what the relative benefits and risks for children are, or where that would. So I don't expect NIAC to come out with an emphatic recommendation as yet. Certainly, they're looking, as you know, at a teenage, age 12 to 16-year-olds, but younger age groups, I expect it's going to be much more complicated.
Sorry, just to clarify then, so, I mean, if we don't vaccinate children, we won't reach herd immunity then?
Well, certainly, if the estimates are that high, that we would need to reach that kind of critical proportion level, it would infer that we need to include age groups going down right to children. But that's just that's based on the current estimate of herd immunity that might be required in order to deal with the increased transmissibility of Delta.
Sorry, just on that, do you know or do you expect any particular time frame on that NIAC advice around 12?
Not on NIAC. So I know they're considering younger age groups than we currently give to, and they're considering other mixed vaccines, other proposals that we're seeing implemented in other countries. So I expect we'll receive, when they've reviewed the evidence and the real world effectiveness and the real world evidence, they'll come back and make the recommendation to ourselves through the Department of Health.
Sorry, just one more from me. You mentioned that an increasing number of hospitalizations will pose a real threat to your plans to tackle non-COVID care in the next couple of weeks and months. What kind of percentage or proportion of non-COVID care and elective procedures are we carrying out now compared to pre-COVID times?
So I don't know that we said it would be a threat in the next couple of weeks. Just the first point, what percentage are we carrying out in terms of non-COVID activity? So we're doing mostly non-COVID activity. So I think the thing that has impacted on us more than anything else in recent weeks has been the cyber attack. So in terms of where we're at, we're pretty much back in terms of the normal activity that we would be doing. And we are bringing in significant numbers of people for scheduled care. And we had scaled that back. So we are very much in a business as usual space, albeit there are still some IT challenges. But so activity-wise, we're coming back, and you can see that in the data I put up. So, for example, that inpatient and day case data, we've really tried to keep that going. Where we see the biggest impact in terms of a growth in a waiting list is outpatients. And that really has been there. That big block have carried through from the surges last year and the first quarter of this year. But to answer your question, we're pretty much back to what we would expect to be doing. The numbers overall, when you look across our acute system, so we have 11,000 inpatient beds, 2,000 day case beds, and we have under 100 people in hospital with COVID. So it's not having an impact in terms of bed numbers. But the reality is that, we have significantly robust infection control procedures at all times. And where we have a growth in COVID numbers, it impacts more and more.
Paul, is there any update on those vaccines from Romania? Have you heard anything more about those? They seem to have fallen off the agenda entirely over the last while.
No, but I know there are active discussions still ongoing with Department of Health officials directly with the Romanian authorities, working through legal, regulatory, EU issues and matters. We would be still hopeful that something can be done to secure a supply line from there, but it seems to be, difficult complications to it.
Any knowledge about what the complications are at this point, or is that out of your hands?
I'm not directly involved, and the officials are negotiating directly with the Romanian authorities, but in any case, there would be legal issues, to be regulatory issues, to be working through some EU governance issues as well. But I do know those discussions are still active.
The impact of those will be less now anyway, given the pace we're moving through the ages. So, it's not to say that wouldn't be welcome in terms of whatever decisions are made about top-ups and so on. But if you look at the pace at the moment that we're moving through the ages, its impact will be reduced from, say, if we had them, 6-8 weeks ago.
Just on international travel, you mentioned it, Paul, earlier on about younger people who'd gone abroad before their full impact of the vaccine had kicked in and then developed COVID abroad. We've also seen this with other people who've gotten in touch with us who went abroad on holidays to Spain and developed COVID over there. Now they're kind of stuck waiting for a vaccine cert or an immunity or recovery cert before they can travel back to Ireland. Do you think people should just avoid travel altogether until they're fully vaccinated at this point?
I think everything got to do with COVID is largely related to making personal judgments and personal risk assessments, whether that's going indoors for a meal or going outdoors for a meal, whether it's travelling abroad or staying here. Everybody should make, certainly travelling abroad would seem to be a lot more cumbersome at the moment. I don't have any plans myself, but people can travel legitimately. The EU certificate facilitates that. Our caution would be to people, particularly as I made a point today, the public health teams have asked me to make that point today, particularly in people in that protected period. You're never fully protected anyway, but to your maximum protected period, you must give that period after your vaccination. And we have seen instances where younger people, haven't done that, got vaccinated, went away straight away and contracted COVID.
Okay, Paul, yes.
Sorry, just one on question on data. The Taoiseach was saying yesterday that he'd asked for improved data around hospital admissions, looking for the number of people who are hospitalised who are being treated specifically for COVID rather than the number of patients in hospital with COVID who could be treated for something else. So are there plans to provide that data? And if so, when will that be?
Yeah, we're working through a range of reports so that we can track this time. Is there any extra information we can capture this time? Is Delta different than the last wave? We have a lot of basic information that we capture. We're trying to see, can we capture some other enhanced information to facilitate that? But I would put out the caution, as I did earlier on, I would not like the public to get any impression whatsoever that the numbers of people we have in hospital are not really COVID cases. The vast majority of people we have in hospital with COVID have come in for COVID and are quite sick. And that was the case when we 2,000 people in January. It is the case when we've 90 people now today, 95 people now today. So, but we are trying to get more information that just sees, is there any differences in trends?
And then finally, just the only other question was, if NIC does approve vaccines for 12 to 16-year-olds, would the plan be that the vaccinations will be done in vaccination centres or wherever they've been done at the minute, or is there a possibility it might be done in schools?
That we're planning through at the moment, like what the mix would be, and it may not be that it's all exclusively one. So I suppose, look, we'll wait the advice from NIAC and the team are planning that out actually at the moment in a session, just in terms of looking at that. But obviously there's options there about how we do it. You look at what's the most effective way and where you get the greatest participation as well. And clearly there's other challenges there as well in terms of young people, in terms of consent and so on, that have to be worked through as well with parents. So that's all been worked through in preparation for whatever NIAC might advise around that without preempting it. No, I suppose we're just saying we're looking at all of those elements. Like consent is one very important part of it. We're very conscious of that in terms of younger people and parents. So that's been worked through as to how that model would work and what would the most effective way, and whether perhaps it may even be a mix of both. But that's something that we'll work through, so that preparation for whatever NIAC might decide, and if they decide to vaccinate young people.
Infrastructure now than we did when we did community or school programs. We've vaccination centres, we've GPs, we've pharmacies scaled up, so we've more options to see how we would do it most efficiently and quickly. Should we get the recommendation?
Okay, thank you all very much.